So welcome everyone who joined. This talk is being recorded. This is a talk of the seminar series of the Center for Mobile, Wearable Systems and Augmented Intelligence. And all the talks are on the center page if you want to rewatch them later or watch past talks. The speaker of today is Akane Sano. She is an assistant professor at Rice University, where she directs the Computational Wellbeing Group. She obtained a PhD at MIT, and before that, she was a researcher at Sony Corporation. And she generally works on effective wearable computing, intelligent systems, and human-computer interactions. Her talk is entitled Toward Personalized and Adaptive Health and Wellbeing Assistance. So after that, Akane.
Thank you. Thanks for introduction, and it's my pleasure to be here and to meet you today. And today I'm going to talk about how we can leverage our personal devices with other information to help our health and well-being. So as you know, we have a lot of devices recently on the market, and I know almost everyone might have some smartphones and some digital devices that allows to capture our moment-to-moment data in our daily life. So how can we leverage this kind of devices and also the data from these devices, which is like 24/7 continuous multimodal data for improving health and well-being? Then, as some of you know, we have this term digital phenotyping. So digital phenotyping means like moment by moment quantification of our individual human behavior, physiology in like real time in daily life, using the data from this kind of personal digital device. So phenotype is originally meaning our characteristics of our trait. For example, like height, length, levels of hormone, etc. blood. Then using this kind of digital phenotyping, we have a lot of interesting, promising future coming in, because as you can see on the slide, if we have patients like carrying like smartphones or wearable sensors, then with some traditional clinical information such as patient report outcomes or EHR, and then these providers, clinical providers, doctors, nurses, they can see how the patients are doing outside the hospital in daily life setting. Then I have some issues with my mouse, but oh, here. Let me use pointer. Then using a lot of data from patient, this data might be helpful for them to make some clinical decisions. Then if the patients are not doing good, then we might be able to develop some models to alert these clinical providers as well as caregivers and patients themselves. So what we are hoping to do is using this kind of data set, we want to detect and predict how patient and also relatively healthy people are doing. And if something is going on, if their health condition is going down, it might be too late to let them know when they reach this point. So we want to know when that is coming in an early stage, and we want to intervene timely. So our goal of our research is we want to focus and intervene to prevent disorders and critical events beforehand. Plus, we also want to provide personalized warning and suggestions to promote people's health and well-being outcomes. So at Rice University, I direct computational well-being group, and we design computational methods and tools for measuring and improving health and well-being outcomes. So we have three main research focus, and one is we are very interested in measuring, understanding human in daily life setting, not in a very constrained laboratory setting. So then we gathered a lot of data from human, then we built robust algorithms for understanding and also understanding humans' conditions, also making decision from the data. We are also designing some applications or intervention support systems for helping health and well-being. So we run a lot of human studies, and recently this kind of observational field studies are increasing more and more. And so our studies target these populations. For example, we study active college students as well as office workers, shift workers. We also do some clinical studies targeting patients with mental health disorders, cancer, epilepsy, and actually our target is kind of growing because a lot of people are interested in this kind of technologies. And in our studies, we combine several sensors. For example, we use wearables, mobile phones, as well as we collect data from surveys, combining with the clinical assessment, EHR. And in our recent studies, we also collect some other information such as blood and MRI. Those are collected in laboratory setting. Then our study can be long term, so can be like 30 days to 1.5 years, and we are collecting more and more data. And we are running some COVID-related project as well. And with COVID, actually, COVID is accelerating this kind of ubiquitous remote human sensing and research. And we are running two studies currently related to COVID. One is about monitoring dementia spousal caregivers using wearables and mobile phones, and to study their social distancing as well as physical and mental health. And we ran another study in collaboration with Microsoft to study how people work in this kind of remote work setting. So we are measuring how people work using the computers, mobile phone, and try to develop some support system to help them increase productivity and health using intelligent agent. And these studies are completely run remotely. That means in the previous settings, we were seeing people participant in the study in person for information session and getting their consent. However, we are now running everything remotely and sending some devices if needed to them. Or we are relying on the devices everyone has without sending anything to the participant. So this is one of our ongoing study, productivity research study. So if you're interested in joining productivity study, please fill out this survey and we will be contacting you. So using this kind of data, also ubiquitous sensors and models, so we are hoping to develop this kind of personalized feedback system. So this is a combination of ubiquitous sensing, and using the data, we want to infer people's conditions such as health, like stress, mental health, or performance, or some clinical events. And not only showing some people, the clinicians or patients, how they will be doing, how they will be feeling in the future, but we want to also close the loop to each individual by providing some suggestions or providing some stimuli to help them promote their health. For example, this intervention can be some micro behavioral suggestions or some passive stimuli providing to users. Then let me briefly talk about what kind of sensors we are using and what kind of things we are capturing from sensors. For example, from wearable and mobile sensing, we can capture so many different things, how they work, how they move, how they sleep. Um, in addition to that, we can also capture various physiological signals. And we are also interested in using contactless sensing. So the first one, these sensors are more like on-body sensing. We have to wear something, we have to carry something, but contactless sensing is something we can capture even without wearing anything, using like radar, using audio, using camera. And we are combining this kind of different modalities to capture human physiology and behavior. Then using the data collected from sensors, we are inferring people's conditions. Then we are very interested in continuously measure and also predict people's condition. Then after that, we are developing some interventions. And again, some interventions include, so we want to provide some micro intervention. So that is a very small behavioral suggestion, because for most of the people, it is very difficult to follow some suggestions and change their behaviors because they are very busy and also they want to stick with their original habit. And we are also developing some low effort feedback, including we can provide some light or some like auditory stimuli to help people like feeling calm down or regulate their heart rate and breathing rate using some entrainment mechanism. However, when we develop this kind of intervention, it's very important to consider when and which intervention strategy we should provide to each individual, because each individual could have different preference, or everyone will be in a different context. So we need to figure out when is a good timing, and among a lot of intervention strategies we can think about, which strategy would be the preferable and mostly likely accepted by each individual. And so using the data we are collecting in our studies, so these are multimodal data set, and we extract a lot of features from raw data and capture some behavioral and physiological markers. And eventually we will connect these features to measure or predict human conditions. However, we have a lot of challenges. As you can easily imagine, these data are collected in everyone's daily life settings. That means everyone can be moving and do whatever they want. Then our data can be super noisy and has a lot of missing data sometimes. And then these are a lot of raw data, raw time series data. So we need to think about how really we can extract informative, useful information from this raw sensor data. And our data is multimodal. So some of them are coming from accelerometer, like heart rate, skin conductance, some clinical assessment, some like blood. So everything might have different sampling rate. And how can we combine this multimodal data? And also another big issue is everyone is different and also changing all the time. So how can we robustly adapt our models to individual differences and also changes in environment and also in individuals? So whenever we run this kind of observational studies, it is not that easy to collect high quality of data. So it's not just like we are providing our sensors to participant, and then we say, oh, then see you like in 1 month or 3 months or 1 year. So while we are running our studies, we will be repeatedly observing how our participants are doing in our studies, and including checking the data quality like daily, because our sensors can break in the middle of the middle of the study. Also, the participant might forget we are wearing sensors. Also, fill out some surveys, or they might be bored in the study. So we are continuously checking data quality in our studies and provide automatic notifications to participants as well as us, study investigators. Because if something is wrong, we might wanna replace the devices, or we wanna provide some feedback to users, to participants. Also, after we collect data, or while we are collecting data, we are also understanding which portion of the data is really noise and which portion of the data is clean. And this is an example of one physiological data, like skin conductance. So skin conductance is like micro sweat response we can measure from our skin. And can be an index of our sympathetic nervous activity. And for example, in this slide, I'm showing you this wristband device to measure skin conductance. And we collect like long-term time series data, so it's almost impossible to identify the noise and also clean data manually. So we need to automate this process. And for that, we developed some machine learning model to automatically identify the noisy portion of the data and clean portion of the data. Then we will be using this kind of information for further modeling and analysis. Then after we collect relatively good quality of data and identifying noise, and so we want to also extract some features, representations from this time series raw data. And in traditional studies, we have extracted features based on some domain knowledge, or we extracted some statistical features. So we call it handcrafted features. However, recently, there are many ways to automatically extract features from this kind of raw sensor signals. Then previously, we have handcrafted a lot of features from this kind of sensor data, from wearables or mobile phones, also some surveys. However, in addition to these handcrafted features, if we can train our models that automatically extract some features, then we might be able to do some features we haven't noticed, however, that are very critical and useful for the model themselves. For example, in one of the studies, we are using this kind of wristband sensors that can capture like eight health signals of skin conductance, skin temperature, and acceleration. So even within a day, we have a lot of data points of this data. And instead of manually crafting features, as I suggested in our previous slide, we might be able to use like deep learning models to automatically extract useful features. Then we developed this kind of autoencoder-based framework to automatically extract features from raw multimodal time series data. So for this one, we developed this locally connected long short-term memory denoising autoencoder to extract features. And how this model works is, so first of all, there are some characteristics of this framework. So first one is locally connected. So we have some locally connected layers at the bottom, bottom line layers, meaning, so we feed pretty long data. In this example, we feed like 1 day of time series data. So instead of using fully connected layers, we decided to use locally connected layers at the bottom layer to limit computation within some separate time frames. Because if we use fully connected layers, it will be a lot of parameters we need to tune. So using locally connected layers, we can reduce parameters to tune, and this can avoid overfitting. Then after we extract some features representation using locally connected layers, we aggregate those static features for temporal features using recurrent encoder and decoder framework. And if we compare this recurrent LSTM-based framework versus static framework, we found out we can learn like better features, meaning we got the reduced reconstruction loss. Then after that, we use denoising autoencoder. So denoising autoencoder, this is one kind of unsupervised learning method that allows us to extract lower dimensional representation from some higher representation of data by reconstructing original data from low dimensional representation. Then we added Gaussian noise to make our models more robust. So using this kind of framework, we can automatically extract features, but we are also interested in what kind of features, what kind of representations are really learned in this framework. So that's why we analyze this automatically learned features with handcrafted features. And this graph shows you some correlation analysis. So we have a lot of handcrafted features on the x-axis, and y-axis is automatically extracted features. And we analyzed what kind of informations are included in automatically learned features. So this table is giving you some information about what kind of information are learned in automatic features. For example, we have the three channels of data: skin conductance, skin temperature, and acceleration. So you can still see this automatically learned features have a higher correlation with a normalized mean of skin conductance. For example, number of peaks in skin conductance. These are the well-known features, important features. And for example, in acceleration, we can see number of step count and stillness percentage. So these features are automatically extracted. Then using this kind of features, we are digging into developing prediction models. Also understanding what kind of behaviors patient or our participant are doing related to their health outcomes. So let me introduce some data example from our studies. This is a study we conducted for college students using wearable sensors, mobile phones, surveys, and this study is called snapshot study. And in this study, we collected 30 days to 90 days, excuse me. We collected 30 days to 90 days student well-being measures, including happiness, calmness, alertness, energy, and health, every morning and every evening. And here on the left side, you can see that this time series, their well-being score. So the lowest is 0 and highest is 100. And from the day 1 to day 30. And this is a grand average. And so if we zoom into this graph, we can still see the students are much happier and better health on weekends because they have no schools. And on the right side, I also want to introduce additional graph. This is the graph from one participant in our study who is unfortunately hospitalized during the study with due to mental health problem. So you can see a lot of ups and downs in this participant data. So using this data for 30 days, we try to understand whether we can find some clusters in their mood. We looked into their average mood versus mood variability. Then we found about like these 3 clusters in our data set. Then some people, they are very high average mood, like happy mood. And they have lower mood variability. However, we have this sad group, meaning they have lower mood, the sad mood with more variability. So our data shows that people with sad average mood exhibit higher variance in their mood. And we are also interested in understanding how their sleep patterns relate to their well-being score. And in addition to sleep duration, we usually care about. In this study, we looked into sleep regularity. And this is some representation from our data. So on the left panel, you can see some example from our regular sleepers. On the right panel, this is the data from irregular sleepers. So regular, irregular means if you have almost exactly the same timing for your bedtime and wake time and sleep duration, that means you have a very regular sleep. So this graph shows you some sense of this regular and irregular sleep. And this x-axis is the clock time from midnight and on the midnight on the next day. And y-axis is a day 1 to day 30, day 40. And so these black boxes, these are the time when participants are in sleeping. So on the left panel, you can see these regular sleepers. They have almost a very regular sleep patterns. On the same time, if you look at these irregular sleepers patterns, we have a lot of irregular sleep habit. And sometimes these people have a lot of naps during daytime as well. Then we analyze how this sleep regularity affect our well-being scores by controlling for their gender, also sleep duration and sleep score at the beginning of the study to estimate causal effect. And what we found here is if we compare these 2 groups, regular sleepers versus irregular sleepers, we found irregular sleepers shows much lower, statistically lower mental health scores, lower happiness, alertness, energy levels. So we are also interested in predicting people's health conditions, such as like the daily mood or momentary mood or momentary mood stress score using the data we are collecting. So our research question is, can we really predict people's mood, stress, health conditions in the future using the data up to today? And one of the challenges we have here is, as I mentioned in the previous slide, we have a lot of individual differences. So that means, for example, what makes people happy, what makes people sad, stress might be pretty different from people to people. And we need to still develop very robust model to adapt this kind of individual differences. So you can imagine some people might be very happy about going to party. However, some people, they might not like working or studying. However, this is not everyone. So we have some other people who really enjoy working. However, might not like going to party much. So in order to accommodate for this kind of individual changes, we have been trying different models. And one way we are doing is we are using multitask learning. This is one kind of machine learning models to allow us to develop model like tuned for each individual or specific group of people while still leveraging the data from everyone. So we have considered and designed different kind of model structures. And so we cluster some of the participants into different groups based on their some characteristics, for example, gender, ethnicity, or personality type. And this kind of model will be helpful to also adapt totally new participant into the model whenever we have new data coming in. And we found out this kind of personalization is definitely helpful for developing our models. Then we also develop our models using automatically learned sensor features I introduced previously. And for some data set, we found that compared to crafted features, we were able to reduce the errors in the models, meaning we can improve the performance of the models using automatically learned features. We are also running some clinical studies to collect the passive sensor data, in this case, mobile phone data from patients with schizophrenia. And our goal is we want to provide some prediction models to clinicians to help them to understand what their patient symptoms are going. And also, we want to also predict when relapse event is happening. And so in this study, in addition to traditional statistical features, we extracted some rhythmicity related features. This is all about how regular or how irregular this patient behavior are, about their sleep, uh, their physical activity, or their communication patterns from their mobile phones. Then we try to develop some interpretable features in interpretable models, including some personalization to help clinicians. And so we, again, we developed this kind of models using some multitask learning mechanism. Then, but we stick with linear regression because using linear regression setting, this model allows us to interpret the contribution of each feature to outcome variables. Then, as you can see here, these are different self-reported symptoms score. For example, hopeful, harm, and seeing things. These are some symptoms, self-reported symptoms from patient. And our models are relatively well predicting how they are feeling, only from mobile phone data. Then, as I said, using linear model, we can understand the contribution of features to this kind of self-reported symptoms. Then, in addition to that, we can also understand the subtypes of patient, because some of the patients are similar and some others are different. So we want to understand what kind of subtypes of patient we can find from the data. And in this case, we found the two subtypes of patient. And as you can see, each cluster, each subtype of patient have different weight of different modality of the data to their symptom. In this case, I'm showing depression symptoms. And then this is another our ongoing study. So in addition to just developing offline prediction models, now we are deploying our health outcome prediction models in the system, then running the machine learning model and providing some feedback to participants, also to clinical staff members. And in this study, we are targeting shift workers. So shift workers include medical doctors, nurses, and they have higher risks in their physical and mental health because of their shifting work schedule. And they have, a lot of them have some sleep issues, also higher risks in many kind of disorders. So our goal is we want to develop some personalized sleep and well-being assistant for shift workers. And so in this case, our participants are shift workers, and they are wearing like Fitbit sensors. And we are collecting some data about physical activity, sleep, and self-reported well-being, burnout, and also work shift schedule. And using this kind of data, we are developing a machine learning model to predict their well-being conditions as well as burnout scores. And in this system, we have medical doctors. They are reviewing the data from shift workers and provide some advice based on cognitive behavioral therapy for insomnia and providing to shift workers. And so currently, we have already developed some preliminary models, prediction models, and we are running these models on the system and providing feedback to this our participant, as well as medical doctors to make some clinical decisions. And eventually, we also would like to develop some another models to help these medical doctors select and decide what kind of suggestions to be provided to shift workers. And the model we developed so far is, so in this study, we have the data from nurses and medical doctors. And we found that these two populations have very different characteristics. So we developed this kind of job type-based multitask well-being predictions. And then we still have a lot of rooms to improve this model, but using some sensor data and some small amount of self-report, now we are able to predict this well-being score. So I have already talked about some of our previous studies, and ongoing studies, then I would like to wrap up my talk by providing some other existing challenges we are currently tackling in our ongoing studies. So in addition to challenges I mentioned previously, we still have a lot of challenges to handle this kind of multimodal time series data from daily life setting. And compared to computer vision or speech studies, it's still relatively much harder to collect big data and also many labels. So in some cases, our labels can be self-reported, especially like mental health related studies. Then it is very difficult to get a lot of data, a lot of labels. And then we are currently working on how can we augment this kind of data? How can we increase the amount of data while still ensuring the model performance also without biasing the model. And a lot of models developed in this kind of studies are very static, meaning that we collect a lot of data and develop models in offline setting. However, our situation, human behavior, physiologies are always changing, and we want to make this kind of model more adaptive to users. So shift work study is one kind of studies we are trying to adapt our models to each individual shift worker in our ongoing study. And we also need to think about how to develop like AI and human collaboration. Because just providing this kind of feedback to users and also providing some suggestion to users might not help. And this kind of system has to be reliable and sustainable and also trustful. And another important thing is user engagement and trust. And in some pilot study, we are able to pay participants to ask them to join our study. However, like paying participant is of course not sustainable. So in practical systems, participant users, they are receiving some useful information to the system to help improve their health and well-being. And we need to think about how to engage users, how to engage participants in this kind of feedback loop system. So in addition to that, currently we are also integrating this kind of moment-to-moment data with some other dimensional, very rich dimensional of human data. So in addition to the clinical assessment, we can also combine this data with MRI, also genetic, some inflammatory markers, and some other clinical assessment to robustly learn some representation of behavior and physiology from each individuals from moment to moment data. So this is almost the last slide. So in the next like 3 to 5 years, I am hoping to continue developing this kind of personalized feedback system to help people like health, well-being, also performance by integrating the sensing, inference, and intervention platform and providing feedback and closing loop to for each individual. So this is the last slide. So I'd like to thank my student, and we have been working remotely since March. And I hope everyone, also all of you are staying safe. And also I'd like to thank a lot of collaborators. So most of our project collaborative, a lot of collaborations within the US, also with Europe and Asia, including academic and industry partners. So I'd like to thank my collaborators, and then thank you for listening and attention. And I'm very happy to take any questions. Thank you very much.
Thank you. I will clap for everyone, and I will look at the chat and hope that we get some questions. I see already one there by Tong, who is thanking you for the talk, and she's curious about the interpretation part. Can all the auto features be matched with handcrafted one? If not, how do you explain what these exceptions indicate? Let's start with that one.
Yes. Can all the auto features be matched with handcraft? So we handcrafted hundreds of features based on our previous research and also domain knowledge. So we correlated auto features with those hundreds of features. And so your question is whether we can um, so it's kind of, yeah, of course we might not be able to handcraft all features. I mean, all handcrafted features can be like enormous number of features, so probably we are not crafting, you know, everything. And so that is a portion we were not able to craft with our hand, but automatically extracted. But sorry, maybe if you could clarify your question, it might be helpful. I'm sorry, I might not be answering your question.
I don't think she can unmute herself. Perhaps Lorena can do her charm to allow Tom to unmute. In the meanwhile, I will ask the second question, which is somehow related. She's talking about multitask personalization. Can you be more specific in how you adapt the model to unseen user promptly?
Yeah, thank you. Thanks for asking that. That is very important question too. So we have tried different strategies to adapt our models to unseen users, because that is more important if we consider like practical application. Then previously, for example, if we train our model to each individual using this multitask setting, then it is very difficult to adapt new users, right? Because each individuals are so different. Then, so how can we kind of balance like personalizing our model to each individual, or personalizing model to each group of people who has some similar characteristics? And also we can think about using like fine tuning our models to new incoming participant using, you know, fine tuning some layers of models in deep learning setting. So far, what we have seen is adapting these models to a subset of, first of all, developing the model to a subset of participants based on their gender or some demographic information or some clinical information, prior information. Then accommodating this new participant, then we adapt this model to that participant. Has been the most successful.
We have a follow-up by Dimitris on personalization. Is essentially saying that you showed some model we feature person-specific layers, but this cannot scale to many users. And he's asking if transfer learning and fine-tuning isn't a more feasible option.
Yes, so we are kind of combining both options. Thank you. Thanks for suggestion. Yeah, so as I said, if we super personalize this model to each individual, then it's very difficult to adapt to. So we kind of need to trade off. So first of all, we can develop like a general model, or we can develop a model for, again, a subset of participant or patient. Then we will be even fine tuning that model into each participant.
I want to go back to Tong so that she can ask a follow-up question. I think she's allowed to unmute now, and then we'll go to the last question by Fahim. Tong. Maybe Tong cannot unmute. Okay, I'll go directly to Fahim's question. Can you comment on your findings concerning sustainable intervention often we notice a yo-yo effect, especially for machine-generated ones. Also, what do you think about future intervention modality beyond today's chart-based visuals?
Yes. So just providing this, for example, like graph or data or some suggestion, even like suggestion might not be helpful, right? Because if you get some feedback from someone else, then just, I don't know, like go to sleep at 11 p.m. Or, of course, everyone knows that like go to sleep early or do exercise more is better for your health. So it's very tricky. Then that's why we are also trying more like non-traditional um, strategies, including like passive stimulation. But that is also, of course, has some concerns as well, because of course we need to get everyone's consent. Also, we need to evaluate the long-term effect, right? Because it might be only working in a very specific setting, for example, however, if they repeat getting the kind of passive stimuli, they might get adapted. Then we might not see the long-term effect anymore. Then so again, this like personalization, like understanding everyone's context, then like tuning, like selecting the, the better strategy to each individual. And also sometimes also a lot of us wanna try something new. So like balancing out like efficacy of intervention, also like some new information. Then because we want to get participants engaged in the study or in the system, so then we don't want to provide the same intervention over and over again. So it is like balancing out several different kind of levers, because we want to maximize kind of like the long-term health outcomes as well as like short-term outcomes, including like user engagement, etc. So I think this will be a like balancing out different outcomes.
Okay, so I now am being reassured that Tom can unmute, so maybe she can ask her question.
Hello. My first question is that given that you use a correlation analysis to explain the auto features, and I understand that not all the features can be handcrafted. So for those features that cannot be highly created to the handcrafted ones, can you explain their physical meanings?
Yes, so yeah, thank you. Thanks for clarifying your question. So I think so far, again, we crafted only like hundreds of features. Those are like well-known features from previous studies. So what we have observed is just only we looked at the correlation between those hundreds of features and autographed features. So of course we might be missing some of the features we are not handcrafted at all. Then if we want to understand the meaning of auto features beyond handcrafted features, yeah, that is a good point. And we might need to we might need to even like handcraft another features. I don't know, those are kind of a little bit tricky. What do you think about do you have any suggestion or do you have any comments about how can we improve interpreting those automatic features?
Well, interpretation in machine learning is still a very challenging topic. So yeah, let's say if there are some new methods to help us to look at the black box we have learned from the data. Thank you for your answer.
Thank you, thanks for your question.
And thank you, Akane. I think we'll stop here with questions.
Mhm.
Thank you again. I'll clap again. Thank you for
Thank you.
agreeing to
Sorry, I
this.
couldn't answer for another question about mixed effect, but yeah, that's true. We could also use mixed effect model because that is via like some repetitive data from each individual. But thank you. Thanks for your feedback.
Great. So we'll stop here.